Hey everybody, welcome to another episode of Innovation Journal Club. My name is Paul Singh, glaucoma anterior segment surgeon out in southeastern Wisconsin. And again, the Innovation Journal Club, the idea is taking peer-reviewed journal articles, OUS experiences, presentations done at different meetings, and take it from that to real-life clinical practice. What do we do every day and how does it impact us as well? So today I'm excited to talk to a really young, awesome ophthalmologist who's doing some really cool stuff, Nandini Venkashwaran. So I pronounced it right, didn't I?
You got
the
it.
The Desi way, I love it. From Mass Eye and Ear as well. Thank you for joining today.
Thank you so much for having me.
Excited to talk to you about some cool stuff. You know, I'm a glaucoma dude, right? I do a lot of anterior segment stuff.
Yeah.
But you know, we've seen so many cool new things happening in the glaucoma space. But cornea too now, we're starting to see a revitalization of some new technologies as well. And today we're going to talk about fibroblast growth factor and kind of what does that mean and how does it impact us in terms of surgical outcomes as well, and talk about something called DSO. So before we get into all that, talk about you, your practice, kind of what you do nowadays as well.
Sure. Well, I'm at Mass Eye and Ear, like you said. I've been there for about 3 years now. I'm kind of a comprehensive anterior segment surgeon, so cataract, cornea, refractive, complex lens exchanges, ocular surface. So my practice has grown quite a bit in all of those different directions.
And I've been following you, so I'm so proud of you. No, I love it. As a guy who's I'm getting older now, so I dyed the beard, so it doesn't. But it's great to see how much you've done and how you're getting out there and then kind of educating others already and doing research. Just really cool to see. So congratulations.
Thank you.
Really happy for you as well. And talk about your exposure and experience with just kind of endothelial cell and endothelial surgery as well with DSEC, DMEC, and DSO. Talk about that.
So, it's interesting, right? Like when my mentors were training me, they did PKP, like full thickness corneal transplants. And then DSEC came along. And then when I was a fellow, DMEC was the craze. We all wanted to do as much DMEC as we could. And now we're starting to think about no transplantation or even injecting cells or other synthetics into the anterior chamber to help repopulate the endothelium. So I think in a cornea practice, you need to not be a one-trick pony. You need to be able to figure out where these different techniques fall in your patient population.
So talk about that. So let's talk about the traditional DSEC. When would you do that real quick? And then maybe when would you do a DMEC? And then talk about what is DSO, the stripping, and kind of when maybe someone would use that.
Absolutely. So I would say that in most of your straightforward Fuchs endothelial dystrophy cases or pseudophakic bullous keratopathy, most of us are now doing DMEC. It has become really a finessed procedure. Patients have excellent visual outcomes, very low graft rejection rate. But then in a tertiary care center like myself, where patients have had multiple glaucoma surgeries,
You're welcome.
they've had vitrectomies, they may have ACIOLs, DMEC is going to be a more challenging procedure to be successful at. And so DSEC has really kind of become what I use in those scenarios, and we've really seen the advent of ultra thin or nano thin DSEC tissue, so sub 50 micron tissue, which behaves sometimes like DMEC tissue.
Yeah, talk about the healing between those two. I mean, are they pretty similar in terms of the visual acuity outcomes?
I would say very comparable, but DSEC still maybe 1 to 2 lines less than what DMEC is able to achieve, and a slightly higher rejection rate if you look in the literature over time. But in terms of the thickness of that tissue, the interface, and how the cornea remodels, it's nice to use thinner tissue, and I think ways of improving how our eye banks are processing the tissue, insertion into the anterior chamber has made that so much better.
Absolutely.
And then DSO kind of came into this whole realm, which is Descemet's stripping only. And like the name suggests, we are removing Descemet's membrane, but we're not really doing anything after. So really the technique is where you identify a cornea, really in Fuchs patients that have, central guttae, maybe in the central 4.5 millimeters, but they have good peripheral endothelial cells. And so if you remove the diseased area and then allow the natural healthy cells to grow back and populate, you're kind of giving the eye an opportunity to fix itself.
To heal itself, I love
Exactly. A lot of studies have now shown the use of Rho kinase inhibitors, kind of adopting from the glaucoma field again.
You're welcome.
Right? I mean, glaucoma is just affecting my life
Keep
in so
helping
many
me out.
ways.
Keep helping me out. Whatever I can do now.
And really kind of using those modalities to stimulate endothelial cell growth and repopulation and function. And I'll even use, Rho kinase inhibitors off-label for patients with chronic corneal edema, maybe after a phaco or even after, DMEC, DSEC, to see if it kind of helps with that. And I've had success with it.
In terms of DSO versus, let's say, DMEC, time for visual recovery, significant difference, I can imagine.
Absolutely. I think it's really setting expectations for the patient. For DMEC, I'm telling patients, we'll do the transplant. It's just not pleasant for about 5 to 7 days. I put SF6 20% to really help tamponade the transplant and keep it in position. And I would say the vast majority of patients do very well. I think rebubbling is real in DMEC, so I quote 15% of the time I'm going to
Okay.
rebubble you, and I set that expectation for patients. And if we do it in the office, a few extra days of supine positioning. And I would say within 4 weeks, they're actually doing really great.
well, yeah.
But with DSO, you're setting that expectation. Patience is a virtue. You're going to need at least 3 months to sometimes see the repopulation of that endothelial
It's a
cell
lot of
architecture.
hand-holding.
Yeah.
I'm with you. We're just doing this together.
Yes.
It's going to be fine.
You can do this.
We can do this together. I'm with you.
Yeah.
So I brought that up because I think now we're going to talk about maybe some benefits using other adjunct therapies like fibroblast growth factor, FGF.
Yes.
Talk about that, and we'll talk about how we can use it with DSO, but talk about what fibroblast growth factor is.
Yeah,
in general.
so fibroblast growth factor is actually ubiquitous. We see this identified in multiple different parts of the body, and it works with different signaling pathways. And there is a specific one called fibroblast growth factor 1 that has actually played a big role in wound healing and has protective effects for the endothelial and epithelial cells of the cornea. So a lot of preclinical studies have kind of shown that it can play a role in corneal wound healing. So how do we apply that in the endothelial keratoplasty or endothelial cell regeneration space? And that's where the STORM 2 study kind of came into fruition, where it was looking at an engineered version of fibroblast growth factor and using it at the time of decimase stripping only. And so this was a specific open label dose controlled escalation study. It had a control group and 3 treatment groups. Your control group just had DSO and they would go through the procedure. But then group 2 used DSO, a priming dose which was done 3 days before the procedure, and then 4 weekly doses given at the time of the procedure and weekly thereafter. Then you had one group that had a DSO with 1 high dose given right at the time of the procedure. And then lastly, you had DSO being performed, a dose given at the time of procedure, and then 3 subsequent doses. So really kind of seeing when do we use this and in what time, how often after the procedure do we potentially utilize it.
Yeah.
And so, I mean, that's nice, right? Right
Yes,
now,
yes.
when we do DSO, we're just stripping the
That's it.
endothelium. It's a 5-minute case and we're done.
Mm-hmm.
But perhaps we can give the patient an adjunct that will help stimulate the regeneration of their
Improve the
endothelial
healing
cells.
time as well. So what
Exactly.
were the basic outcomes of the study?
I mean, the outcomes really show that there was an accelerated improvement of vision and a resolution of corneal edema with injection of the synthetic fibroblast growth factor. And 46% of these patients actually had cataract surgery at the same time of DSO, and they actually didn't find a difference in how these patients improved.
That was
with
surprising.
injection
Even
of-
looking at pachymetry, they
Yeah.
didn't see a difference between the two
Right.
groups as well.
Yes.
Was that surprising to you?
I mean-
I thought there would be a little bit.
I guess whoever's doing these surgeries is
Pretty
really
damn
talented.
good. Some pretty good EPT there, right?
Exactly. But I mean, it also suggests many of us are doing DSO at the time of cataract surgery too. Clinically, it's very relevant because DSO is not always an isolated procedure in a pseudophakic patient. You may need to utilize it in your cataract surgery patients. So are we able to accelerate healing time at the same time for cataract surgery? That's important.
And talk about the outcomes in terms of effectiveness. And was there a significant difference in the groups at all that you noticed?
I mean, it really struck me that group 3 was the most successful, though. So that is doing the DSO and injecting a high dose of the synthetic fibroblast growth factor. We were seeing improvements in the vision at about 28 days post-injection and post-procedure, and kind of seeing an improvement of the vision overall over the course of 2 months. So definitely in terms of timeline, perhaps a little faster than just DSO traditionally, but still maybe taking more time than, say, a DMEC.
Yeah.
Right? So you have to think about it in terms of what are you comparing it to, DSO only or some of your EK procedures.
Now, compared to, let's say, a DSEC, what do you think? Because DSEC, what do you think time-wise?
I tell patients it can take up to 3 months.
So
for
do you think this is
DSEC.
kind of comparable
I mean,
time-wise?
maybe a little better.
A little better, right?
Yeah,
That's
a
what I was
little
thinking
bit
too.
better. And you don't have an interface, you don't have tissue in the eye, you're not
Rebubbling.
committed to, you're not rebubbling, you're not committed to steroid drops for life. Say you have comorbidities, you have ocular hypertension. This is kind of an opportunity where your body is doing its thing and you're not as dependent on external factors.
And so this is not quite yet approved yet, right? We're still in the study.
No.
Just make sure everyone's clear about that.
Still,
These are earlier
still
studies.
in studies, and obviously kind of understanding what its role is and also its safety profile, seeing how patients do long-term with this therapy, and we have follow-up for a certain amount of time in these studies, but of course we want to do long-term follow-up to see, do these endothelial cells stay? Is there any decompensation? Are these patients needing to be rescued with EK later?
And that's exactly
interesting
right.
thoughts.
And I know we're not going to talk about this today right now, but there's also the application of fiberglass growth factor for epithelial healing too as well. So that's kind of a nice, I think we're, this new concept of really adjunct therapy to our traditional surgeries.
I mean, the epithelium loves or hates you sometimes. So to find ways to help repopulate, I mean, I think we've seen a growth in that space as well. And so this could be another adjunct, but how do we administer it, right? This was an intracameral injection.
Versus topical drops.
Maybe topical drops. Can you synthesize this in a membrane format or some sort of, contact lens vehicle, delivery? That could be very interesting.
It was really interesting. I was reading about it earlier too. With this formulation, I know Trefoil, the company that made it, they really were able to increase the half-life. I mean, that was something because the half-life of fiberglass growth factor is pretty short, so they had to do some engineering. Is that
they did? I believe they altered the cysteine residue. I think that's what allowed it to be, more viable and also less effects of oxidative stress on it when it was used inside the eye, and so I think that's what helps it succeed.
Exactly.
But I wonder how long it stays there. Like that's something I need to look more into. But how long is it staying in the anterior chamber? How long are its effects actually happening?
Because you're having obviously outflows, naturally as well. But it is interesting. Talk about I know we still don't have a lot of data yet. It's still early on, but hypothetically, this is available to you today based upon the data you had. How do you see this affecting you in terms of the number of DMECs that you would do compared to DSO, or even maybe opening up DSO to maybe a larger population of patients? Would that be something you're thinking about now?
I'm more of a DMEC person in general because I like expedited recovery for my patients. I'm an instant gratification person.
Sure.
But I think there are a cohort of patients that just don't do well with EK. The compliance with drops, the positioning, kind of the long-term effects of, rejection, graft failure. I mean, eyes that have had multiple surgeries, graft, longevity is limited. That's what the literature shows. And so maybe if I can offer a DSO in these patients, they may not have the best peripheral endothelium, but if I'm able to give them a synthetic fibroblast growth factor and say, okay, I can start the process of endothelial recovery for you, maybe this will be a transplant-less option and you could succeed. I don't know if you would do well, but it would maybe open up that door for more patients.
And can you do a DSO and then do a EK later on?
Yeah.
If you need to, right?
Yeah, so after 3-4 months, many of us, if we're not seeing enough resolution, we'll use a rho kinase inhibitor. Persistent edema, you can do a rescue DMEC. You may just have to strip more because our grafts are typically 7.5 to 8 millimeters. So you'll just strip, but you can easily put a graft in that position. With DSO, we don't strip. We actually almost do like a reverse capsular rhexis. And it's supposed to create a really nice, smooth transition between the desmetarrhexis and the peripheral endothelial cells. That's what allows for the smooth migration. When we strip, it's actually coarse and not as fine-tuned, and that can actually inhibit healing.
Thank you so much for joining us today. This was awesome.
I learned
a lot. So the question I was asking was not because of anybody out there, because I was like, I'm curious. So that was really, really nice. So thank you for that. Appreciate it.
Of course. And I mean, look at the synergy between the cornea and glaucoma.
So when I put a tube, I also do a DSO at the same time.
DSO at the same time.
Save myself an extra trip for the OR. Now I want to think about that. But thank you again.
Of course. Thank you so much for having me.
Thank you. And thank you everybody for joining us for another episode of Innovation Journal Club. Hopefully we'll have another episode coming your way shortly. Thank you so much. Take care.